Hi, I'm Tony Cristiani, a Simulation Program Administrator here for SeaStar's Baltimore SimLab. With the assistance of Mr. Dan Goodman, our Sim Operator, we're producing a video today to help acclimate you to your simulation training, specifically the Laerdal SimMan 3G, which is the simulator you will be using during your training here. So I'm standing here in Trauma Bay 1, and you can see multiple pieces of equipment, all real-world deployable equipment, the 731 vent, the 330 suction, your triple channel pumps. We got stock carts, CPGs, telephone, kind of some of the surroundings in the real estate here in the lab. It's very realistic as far as a lot of different things that you'll be able to do and perform throughout your scenario when you're doing your assessments and interventions. Specifically, one thing is he has two-way voice communication, which is really nice. So if I do a tap and shout, "Hey sir, what's your name?"
Hey, my name is Dan.
How are you, Dan? Can you tell me where you're at and what year it is?
Yeah, I'm alright. It's 2022, and I'm at SeaStars, Baltimore.
Excellent. Thank you very much. So you can see two-way voice communication. So talk to your patients when you're coming on and exposing them and getting that initial information and feedback from them. They will talk back to you. There's also pre-programmed voices in the software where we can manipulate different sounds, i.e. coughing, maybe a vomit or something of that nature. His eyes blink and his pupils respond. So if I were to take a pen light and shine it into his pupils, "Sir, I'm going to check your pupils out and see what they're looking like." I can see that the right pupil is equal round and reactive, and the left pupil is not doing anything, so it is blown, and that obviously is an indication of something going on in his head. And so that's a very nice feature when we're determining our Glasgow Coma Scale, GCS, on these simulators. If I look specifically at his head, there's some really nice things that can happen, a lot of features just in his head itself, where we can do lots of different things. For example, we can have him bead up and sweat. You can see some sweat dripping off his forehead. We can have him cry or tear up. We can have discharge come out of his nose, froth at the mouth, and we can have cerebral spinal fluid, CSF, leak from both ears. The voice that you heard coming from the simulator are speakers in the top of his head, and the microphones that allows the operator to hear you communicate with the patient are embedded here in his ears. The airway on this simulator is completely functionable, so you can intubate it orally, you can intubate it nasally, and you can actually perform a cricothyrotomy on this patient. Some neat things that the software allows us to do, where we can make the airway challenging or difficult for you as a student, are, and I'll demonstrate here, Dan's going to demonstrate, we can do tongue edema, we can do laryngospasm, we can do foreign body airway obstruction, and we can do trismus, where we're going to do lockjaw and clamp him down. And then the last thing is decreased cervical range of motion, where we make the neck really, really tight and stiff. So now what we're doing here is putting him in can't intubate, can't ventilate mode to actually force you as a student to perform a cric. Performing a cric will be the only spot that will allow you to actually make an incision in this guy, and you can feel your landmarks of Hump Valley Hump, and then there's a piece of tape that you would also pierce through representing the membrane. You can maybe see it there. Some other features are, as far as oxygenation, has the capability of presenting with cyanosis. So once the oxygen saturation dips below a certain threshold, there will be this little blue LED light that goes off inside his lips to allow you to know that you have cyanosis. And then obviously you can apply oxygen. Laerdal SimMan 3G also has the capability of shaking and being cold, so he can shiver and demonstrate that he's cold. So he's partially exposed with a blanket only on him halfway. So if Dan can show that he's cold and shivering, hopefully you can see that. And then another way we can utilize this feature is to represent he's having a seizure from a traumatic brain injury. And then a third way we'll also utilize this feature is if a patient is administered succinylcholine, we completely paralyze him, his eyes get shut, respirations go away, and now you know he's muscle fasciculating, and you can proceed with a nice, smooth, rapid sequence intubation. If we move down into his chest and we talk about breathing and the rest of his airway stuff, respiration. So listening to breath sounds and palpating, between auscultating, palpating, and visualization, we should be able to determine what's going on with this patient's respiratory status. So just by palpating, I can see and feel, I can just palpate that I am getting chest rise and fall unilateral and only feel chest rise and fall on the patient's right. So if I were to grab a stethoscope and take a listen, hopefully between palpating and auscultating, I can come to a nice conclusion that I have no breath sounds on the left. Also, while auscultating breath sounds, I want to listen to my heart tones, just like ATLS teaches you. So aortic, pulmonic, tricuspid, and mitral. And I do not have breath sounds on the left, so it tells me this patient has a possible pneumothorax. My first intervention would be to do a needle decompression, which you absolutely can do on the SimMan 3G. Second intercostal midclavicular. If you choose anterior needle decompression, there's a small air bladder underneath the skin, so if you hit it appropriately, you'll actually get to hear an audible hiss like you're taught in real world. The new guidelines, TCCC guidelines, are teaching us nowadays to do fourth or fifth mid-axillary needle decompression, which you absolutely can do, but be cognizant that there's no air bladder on these sides. You'll hit hard plastic. So if we were doing needle D, another intervention to follow up with a needle D would be a chest tube. Laerdal gives us this little tab here on his side where we could actually put a chest tube, if I were to take a 36-French chest tube up underneath the skin and slide it in there. We will not allow you to actually make an incision and cut, but that would be a big simism, and we would verbalize that throughout the scenario. And then you could insert your chest tube and hook it up to your appropriate atrium and suction, and then press forward with an x-ray. Other sounds that this simulator has are bowel sounds. So if I was to auscultate and put the stethoscope and listen to his stomach, I would be able to hear bowel sounds. We can manipulate sounds, increase in volume, and changing them up according to many options and selections that the software provides for us. Talking about circulation, pulses are present just like you and I on the human body on this simulator. We have bilateral carotid pulses, left brachial pulse. The only pulse this guy does not have is a right brachial pulse. But we have bilateral radial pulses, and I'll expose him a little more. So bilateral radial pulses, which I can palpate now. Femoral pulses, and you can see the boxed out window. And this is the spot I tell all the students to go for. They're the easiest to see and palpate. And if I come down here in here to his lower extremities, we have posterior tibialis bilaterally. And I also have dorsalis pedis pulses. Here in SeaStars Baltimore, we have a slightly different process for doing IVs on the simulator. And we have a wearable device that's not made from the Laerdal manufacturer. And so this allows you guys as a student to actually do venipuncture on the simulator by sticking a simulated vein with simulated blood and a safety plate that you cannot pierce through. Therefore, you cannot mess up the simulator. Once you establish an IV access, then you'll utilize the J-loop that we provide for you to administer your IV push, your pain medications, crystalloids, or blood products, whatever it is you choose to give. If your patient comes to you with an IV, that J-loop will be present and hanging out at the top right-hand corner of this device. And if your patient does not have an IV, let's suppose on the right arm there is no J-loop showing, then you would perform your venipuncture, secure the IV, and then at the top right-hand corner, pull your J-loop out, and now you have your IV access. Talking about GU, so right now equipped with male genitalia, could very easily swap out and turn this patient into a female with some female genitalia, but you have the capability of performing urinary catheterization or indwelling catheter by performing aseptic technique and utilizing the Foley kits that we provide for you. There's a small reservoir inside where we can fill it up with simulated urine, and you may or may not be able to get a urinary flash once you insert your Foley. The other thing too is we do not want you to use betadine on our simulators as it stains the skin. Also ink, no ink in the lab. If you look at this here, at the top of his head, there's a tube that comes out of the back of his neck. This is part of the IV system, and it just goes to a bucket. So when you guys are administering your fluids and resuscitating these simulators or your patient with blood products, everything you're giving the patient is going to go through this hose to a bucket underneath the bed. So for the sake of the scenario, just pretend you don't see that. When we're log rolling these guys, we're going to maintain good C-spine stabilization, and we want to always turn the simulator to the right. There's a power cord that's plugged into his hip, and if we go to the left, it sometimes will come undone, and then we will lose complete power and function of the simulator. So to avoid all that, we ask you that you maintain good C-spine stabilization, and on the count of 3 with the team, that you would log roll to the right, and then you can perform your palpation of the spine and check for rectal tone. When we're talking about hooking the simulator up to vital signs, You're going to use the ProPac M or MD, whichever is at your bedside. This Trauma Bay 1 currently has the ProPac M. When we're hooking up vitals with the ProPac M to a high fidelity simulator, you do not have to turn the ProPac on, as Laerdal and ProPac do not communicate. Okay, so if I unhook and open this up, the first vital sign I would like to hook up is going to be my pulse ox. And if I place that on his finger, any finger or toe or maybe an ear, you'll get your pulse ox up on the flat screen here that we show you. And then I can go to blood pressure. Sir, I got to move your arm around and put a blood pressure cuff on you. You're going to feel this pump and squeeze on your arm every so often, okay? It's going to take your blood pressure. You see how I talk to him, let him know what's going on. So now the blood pressure cuff is going off, and that's going to populate the bottom left-hand part of the screen. And then lastly, we will use a 4-lead EKG. So it'll be right arm, right leg, left arm, left leg. There's nowhere for the V-lead to attach, so don't worry about that. And then once these leads are hooked up appropriately, then your EKG tracing will populate on the flat screen also behind me. If you get your wires crisscrossed, we're watching you, so you won't get a tracing. All right, so now you can see your blood, all your vitals are up here on the screen. Say this patient comes to you from a roll 2 where they did damage control resuscitation surgery, and he comes with some invasive monitoring such as an A-line, and maybe he's intubated from the surgery and he's got end-tidal hooked up. If there's an A-line, then we'll show you the A-line tracing. If the CO2 is hooked up appropriately from your ProPac to your circuit and coming from your patient, then you'll see an end-tidal CO2 tracing as well. You do not have to touch this monitor or ask for vital signs. We'll repopulate vitals every so often in the scenario. Typically it's every 2 to 3 minutes, like you can hear the cuff going off now. This flat screen is to be touched by cadre only, and it's also used for labs. So when labs are sent off in the scenario, we will show you your lab results up here. And when x-rays are performed at the bedside, we will also show you an x-ray image, so that gives you something to diagnose. I think that concludes the Laerdal SimMan 3G and its capabilities. Thank you.